So today we are incredibly fortunate to have Dr. Gayle Woloschak from Northwestern University for today's presentation on radiation and cancer biology. We hope that this will be a good summary for those of us who are taking the qualifying examinations next month. But please know that the content of this presentation hasn't been reviewed with the ABR, and Dr. Woloschak is not involved with writing any of the questions on the examination. So before we get started, I'd like to go over a few things. So this presentation is currently being recorded. We hope to have a recording of this presentation on the ASTRO/ARRO website within the next few days. Please make sure that your call is muted, and please mute your video as well if you haven't already. So because of the number of people who are probably going to join today, we're not going to be able to have a question and answer session, but if you do have questions, Dr. Woloschak said that you can email her, and she will be talking about that. So now I'd like to introduce Dr. Gayle Woloschak. Dr. Woloschak earned her PhD in medical sciences at the Medical College of Ohio. Let me click this. There you go. She completed her postdoctoral research fellowship at the Mayo Clinic in Rochester, and she's currently on faculty at Northwestern University, Feinberg School of Medicine, as professor of radiation oncology, radiology, and cell and molecular biology. She's also the associate dean for graduate student and postdoctoral affairs at Northwestern University. She also continues to lead an active laboratory at Northwestern. Her primary areas of research include molecular biology of radiation responses and bio-nanotechnology. She's actually a member of the U.S. delegation to the United Nations Scientific Committee on the Effects of Atomic Radiation. And in 2017, she testified at a hearing for the House Committee on Science, Space, and Technology regarding the importance of low-dose rate radiation research. Also, she was the editor-in-chief of this year's ASTRO Radiation and Cancer Biology Study Guide. And as a current resident in the department at Northwestern, I can say that we're really fortunate to have her on faculty as a teacher, mentor, and friend. But she's very busy, so on behalf of the ARRO Executive Committee, we're really grateful that she's willing to dedicate a few hours of her morning to give this lecture. So I will now turn the presentation over to Dr. Woloschak, and it will be all yours. So give me 2 seconds.
Okay, everybody, I'm sorry that this is not a presenter in a better mode, but I think we can get through like this. As Chilane said, I'm Gayle Woloschak, and there's not going to be enough time to handle questions, and I think from this larger group it would be very difficult. So I've put my email address on, and if anybody has questions, please feel free to email me. I'll do my best to get back to you with answers. And you know, I've also noted that if anybody has any comments on the ASTRO practice exam, we found some errors in it, and some of you have been kind enough to point those out. Please feel free to send me any comments on that as well. Okay, this is not working either. Here we go. Okay, so this is the classic paradigm of radiation injury. We know that when radiation intersects with matter, it can do two different things. It can just cause excitation and release heat and light, or it can actually cause ionizations itself. The ionizations can be chemically repaired. I don't even know if you can see my mouse. It can be chemically repaired, or the damage can accumulate, be enzymatically repaired. If the damage accumulates and leads to cell death, the results of this can be acute radiation effects like radiation sickness, developmental effects, and even late effects. If it does not lead to that much cell death, you can still get mutations that are induced. Germline mutations are going to lead to heritable effects. Somatic mutations can possibly lead to cancer. But let me note that the most common late somatic effect of low-dose radiation is cancer induction. The early events take place within seconds to minutes. These set the stage for things that can take place years later, which would include cancer, some late effects, and even generations later, which could include heritable effects if they do take place. Here are some official definitions, and I would learn the Becquerel. The Becquerel is 2.7 times 10 to the minus 11th curies. We tend to use the curie in the clinic. It's defined as being equal to 1 disintegration per second. The curie is 3.7 times 10 to the 10th disintegrations per second. The gray, as you all know, is the unit of absorbed dose. It is dependent on the amount of energy that's deposited per kilogram, so it's dependent upon body weight. It's officially defined as 1 joule of energy deposited per kilogram. If we went back to old terminology, the old terminology would be the rad. The sievert is the unit of dose equivalence that we'll talk about in a little bit. It's where we multiply the absorbed dose in gray by the quality factor, and we get the sievert. We'll look at the quality factors in a moment. LET, linear energy of transfer, is the measure of the rate of energy that's transferred from ionizing radiation to a target material. It's usually expressed as kiloelectron volts of energy deposited per micron track length. And here are just some conversion factors. Some of these, 1 sievert equals 100 rem, 1 rem equals 0.01 sievert, 1 gray is 100 rad, 1 rad is 0.01 gray. I would also learn the 1 becquerel is equal to 2.7 times 10 to the minus 11 curies, and 1 curie is equal to 3.7 times 10 to the 10th becquerels. Here are other definitions that are much the same, and I will tell you that that normally dose rate is expressed as gray per second. The rate of exposure is usually in Röntgen. Now, in radiation protection, we use different types of measures, and frequently people confuse equivalent and effective dose because they both begin with an E. Equivalent dose is the average dose times a radiation weighting factor or a quality factor. It's expressed as sievert. The effective dose is where we take into consideration the exposures to organs and tissues that are involved. So it is the dose times the radiation weighting factor, again being corrected appropriately for organs and tissues. So it's usually set up so you can get partial body exposures. It too is expressed as sievert. The committed equivalent dose is an equivalent dose that's integrated over 50 years, expressed as sievert. And then there's the committed effective dose, which is integrated over 50 years for the effective dose, and it too is expressed in sievert. So here we have 4 terms that are expressed in sievert. I would probably know all of these definitions, but in particular, the equivalent dose and the effective dose are the most important. There's also the collective effective dose and collective effective dose committed they're expressed as person sievert, and they deal more with populations. Okay, what are the exposure levels that we find in the U.S.? This is a map of our exposures. Down here, we have an exposure in the southern coast along the Florida coast of 0.23 millisieverts per year. This is the exposure at ground level. It does not take altitude into consideration. We have a similar dose up here in Minnesota and at the tip of Michigan. The rest of the U.S. is at 0.46 millisieverts per year, except in the so-called, in where our uranium mines are out here in the west, mostly in Nevada, where you can see these pink areas. Those are 0.9 millisieverts per year. I would know the natural background in the U.S. At ground level. Now, what does our natural background do? Today, most people would say that we have about as much, maybe a little bit more from medical exposure than we have from natural background. From medical exposures, most of that is from CT scans. A small amount of that's from nuke med. Interventional is next is conventional. These percentages are a little bit changed today. This is from 2008, but there hasn't been a new pie chart that's been published since. So this is the most recent pie chart. I would also know that the majority of our natural background, which makes up not quite half of our exposure, although it says half on this pie chart, is from radon and thoron, space background, the internal whatever we ate today. Potassium is very common in our diet, and then the terrestrial background that we get from the Earth's crust. Now, this chart was also done by NCRP, and it says that the average exposure of the average U.S. person is 2 millisieverts per year from radon, plus approximately 1 millisievert from these other sources, which include terrestrial cosmic rays and radionuclides in the body. This adds up to approximately 3 millisieverts per year as the average background in the U.S. That doesn't mean every person gets 3 millisieverts. Some people live in higher radon homes and get more. Some people live in lower radon areas and get less. But the average for the U.S. exposure is 3 millisieverts per year. The dose limit that we set for the general public is 1 millisievert per year. I have a better chart of that in just a few moments that will explain that better. Here are some average exposures for other events that one might experience. I also have some better numbers for that in a moment too. Okay, let's start to look at what happens when radiation actually affects matter. There are two types of actions that we talk about. One is the direct action, where the radiation hits the DNA backbone directly, or the DNA base. This can lead to DNA damage directly. The second is an indirect action, where the radiation hits a water molecule most often, but there are other molecules, but because our bodies are 95% or more water, hitting water is most important. This can give rise to a hydroxyl radical. If the hydroxyl radical is in close proximity to the DNA, it can cause damage to the DNA. So let's look at this a little more closely. This direct action then does not involve any intermediates, and therefore it is a direct action. Direct action can occur from both high and low LET radiations. It is the predominant but not exclusive damage from high LET radiations. The indirect action is 2/3 of the damage that comes from low LET is indirect, 1/3 is direct. For neutrons, the majority of the action is direct action, but there is a little bit that can be from indirect action. Nobody's really put percentages on it accurately. What about this hydroxyl radical? If the hydroxyl radical is produced someplace far away from the DNA, it can't be close enough to cause this damage. It gets eaten up by free radical scavengers in the cell. If the hydroxyl radical is produced in close proximity to the DNA, which normally means a water molecule that is touching the DNA directly, in this example, it would be approximately 2 nanometers radius, 4 nanometers diameter around the DNA. If the hydroxyl radical is produced in that area, it can cause DNA damage as well. Now, it's important to understand the distinction between stochastic and deterministic effects. We usually consider stochastic effects those effects that are determined by chance. I don't want to mislead you. I believe at the molecular level, all damage is actually stochastic, but what happens is we tend to call stochastic those things that we can pick up at the single cell level, like a cancer or like a mutation in an egg or a sperm, and we tend to call deterministic effects those things that happen in organs, mostly when there's sufficient DNA damage to be able to cause cell death. There are two severity states that occur for stochastic effects. Either it's present or absent, so either you have a cancer or you don't. You don't have a worse cancer because you got exposed to a higher dose. For deterministic, we do have severity states, and we use those clinically for trying to determine, who has bad, do you have a 1+ or 2+ toxicity. For stochastic effects, by definition, there's no threshold dose, so therefore people claim that there is a risk from even the very lowest doses. There's the risk of a mutation or a cancer from the very lowest doses, but the risk goes up with dose. So therefore the risk at low doses is less than the risk at high doses. You therefore can detect stochastic effects at low or high doses. Whereas deterministic effects do have a threshold. The severity does go up with dose, but it usually goes up pretty dramatically with dose. It is usually intermediate or high doses that are responsible. The dose-response curve for stochastic effects is usually linear quadratic, or and it's normally linear quadratic with no threshold, whereas the dose-response curve for deterministic effects is usually threshold with a sigmoidal curve. The stochastic effects are normally relevant to radiation protection, to diagnostic radiology. The deterministic is normally relevant to normal tissue toxicity, early and late effects. And as I said before, the main example we have for stochastic would be cancer, or it would be induction of mutations in eggs or sperm. For deterministic effects, examples would be cataracts, normal tissue toxicity. Most of the radiation, acute radiation toxicities fit into this kind of category. Okay, So let me now go into some of the abnormalities or aberrations that are associated with chromosome and chromatids. Chromosome aberrations are usually experienced at any exposure during any time of the cell cycle. They can occur in G0, G1 phase of the cell cycle. What is the most common phase of the cell cycle? In normal cells, it's G0. In cancer cells, it's often G1. So therefore, chromosome aberrations are more common than chromatid aberrations, which occur only after the cell has duplicated the genetic material, which is normally late S, G2, perhaps early M. The idea with a chromosome aberration is that there's a break that occurs in a strand of chromatin. It replicates in S. You observe all chromosome aberrations during M phase. The standard examples would be things like translocations, maybe small deletions, which are non-lethal, and dicentrics and rings, which are both considered to be lethal. Many times we use dicentrics for doing dose estimates. The sensitivity is around 25 centigrade.
Inpatient.
Could somebody mute your line? I'm sorry, I'm hearing noises. So the 25 centigrade is usually the sensitivity. Would we ever use a chromosomal assay to answer something about a patient that is in our hospital? No. We only use this. There we can use physics to tell us the dose. What we would do is use these only for an accident that has taken place where we don't really know the dose and we're estimating the doses. Then we'd go after something for dicentrics. Dicentrics are usually used early after radiation accident. Why would we use them for dose estimates early? Because the cells die because it's a lethal aberration. So then we'd be left with having to use translocations, which have a natural background that's quite high in the population and are not ideal for doing any sort of guesses in dosimetry. Chromatid aberrations occur when the cells are radiated after S, after duplication of the genetic material. Radiation causes normally a break in both chromatids. You observe it in M phase. And the main example that people talk about is the anaphase bridge, which looks like a bridge during anaphase. It is a lethal aberration. There is a correlation of chromosome aberrations and disease. We know physical abnormalities, mental retardation, cancer, and lethality can all be the result of these kinds of abnormalities. Now, there are a few things that need to be stated about radiation genetics. First of all, there are no really unique mutations that one finds from radiation. There are a lot of people that are arguing about whether there are particular kinds of lesions that one finds in particular cancers, but right now, because radiation causes single-strand breaks, double-strand breaks, the standard things that one would find, and point mutations, the standard things one would find following almost any effect, there's nothing that allows us to give us a signature to say, oh, this came from a radiation induction. I will mention that most mutations are not detected. Those that are detected are most often dominant because they involve a single gene. Recessive mutations are harder to detect because they usually have to have both genes that are affected. Mutations are generally rare. Within the same species, there is a variation in spontaneous mutation rate, and therefore in the vulnerability to mutations, and the number of mutations is generally proportional to dose. So as you increase the dose, you have a higher risk for developing mutations. The doubling dose for male mice for acute exposures is around 20 to 30 centigrade. If it's a protracted exposure, it's around 90 to 100 centigrade. This is for low LET exposures. The mutagenic hazard in humans is estimated to be about 2 to 3 times 10 to the minus 7th mutations per gene per centigrade of exposure. This is questionable, and I think the Hiroshima and Nagasaki data are going to argue against this, but right now the published period at risk is 10 genetic generations of 30 years, which is 300 years. I don't think that's in keeping with what we're seeing from Hiroshima and Nagasaki, where we're not really seeing effects in even grandchildren of those that have been exposed. So be cautious when you look at these numbers. The genetic maximum permissible dose limits we'll talk about in a moment, but for occupational exposures are 50 millisieverts per year, and for the general population are 1 millisievert per year. You all probably know this, but just to make sure that it's in here someplace, when we look at radiation in the cell cycle, we know that cells are most sensitive to radiation at or close to M phase. They are in G2 phase almost as sensitive as they are in M, and there are sometimes when they're actually more sensitive, so that's one of the exceptions to the rule. Most people would put M and G2 together as being equally sensitive. They're most resistant to radiation in late S, and if there's a prolonged G1 period, there's a resistant period evident early in G1, followed by a sensitive period late in G1. If there's a short G1, this distinction is often just hard to detect because it's too short to be able to see it well. Okay, so let's talk for a moment about what happens now when we put these these chromosome aberrations into a response curve. This is a plot of the dicentrics that exist per cell against the dose. And what people found was that there was this curve that looked like this. This was plotted very early on by Mike Cornforth's group. And what the idea was that this curve was neither linear nor quadratic, but both. The low dose region was linear, the high dose region was quadratic, and the question became, at the low doses, how can we even possibly get a dicentric? A dicentric means that you've had two hits through two chromosomes. These two chromosomes now give rise to a dicentric. How could this possibly happen? It has to be that one track is coming through and causing two injuries. There's no way that at a very low dose, where you're getting maybe one traversal per cell at best, that you can get multiple tracks coming through and causing multiple damages. So this would be a rare event, but when it does happen, the aberration that happens at low doses occurs when a single track comes through and causes two aberrations. This gives rise to the dicentric, which leads to cell death. As I said, rare. At high doses, there are lots of tracks coming in, so it's much easier to understand how you have one track causing one injury, another track causing another injury. These come together, give us the dicentric, which leads to the cell death. So the idea was that in order to come up with the mathematics to explain the combination of this curve, one required both linear and quadratic mathematics. Linear would be some constant called alpha times the dose, because that's the definition of a linear response. And the quadratic would be some other constant called beta times the dose squared. This now led to this linear quadratic response. Here's the equation that was used early on. The yield of chromosome dicentrics is equal to alpha D plus beta D squared. If we look at the contribution to killing, then what we see is in M and G2 phase cells, the alpha killing is a large proportion of the amount of killing. Beta is, while not zero, it's nil, it's very small. For G1 phase, the alpha is large, the beta is small. For early S, alpha and beta are both medium, and for late S, the alpha is small and the beta is large. What then this looks like in terms of cell survival curves is as follows. This is a model of the linear quadratic survival curve. Here we have log of the surviving fraction against the radiation dose. Let's just focus on the low LAT curve shown here. What we see here is that there is an alpha and a beta component to the curve, and the alpha-beta ratio as defined as the dose at which the linear and quadratic contributions to cell killing are equal. The linear quadratic model that we've used for a very long time now, and which is the most accurate model for describing the relationship between radiation and effect, is the fraction that is surviving is equal to that exponential number e taken to the minus alpha d minus beta d squared, where alpha and beta are constants, defined here by this alpha-beta ratio. Again, being that dose, and it's always expressed as a dose because you're comparing dose to dose squared, it's a dose at which the linear and quadratic contributions to cell killing are equal. Now, I want you to notice over here that this is the curve for high LAT radiation. Neutrons or alpha particles would fit in this particular curve. You do not see that there's labeled an alpha-beta ratio, because for densely ionizing radiation, the alpha-beta ratio is so very, very high that we can't really see it. This is all alpha killing that is depicted here on this high LAT curve, so we can't really compare alpha and beta ratios, and indeed very few people talk about alpha beta ratios for high LAT radiations. Now, there is an old model that people have used for a very long time called the target theory model. I don't want to go a lot in the target theory model because people have been pulling away from that model to a large extent, but I will mention the D0 dose, which is considered to be an important component to it. The D0 dose, and normally the target theory model works very well in cell lines. It does not work so well when one considers tissues. We tend to like the linear quadratic model much better when we're referring to tissues. When we're talking about cell lines, we talk about this thing called the D0 dose, which tells us something about the shape, the slope of this beta portion of the curve here, and it is, or actually the part of the curve that looks like a straight line. And this part of the curve that looks like a straight line is normally, we go from, in this example, 0.01 to 0.00037, and look at the dose in between there to give us the D0 dose. There are some cell lines and situations that give us this straight kind of line, which we would say follow single hit, single target kinetics. The three examples that look like this would be high LAT radiation, cells that are in M phase of the cell cycle, and number three, cells that are missing DNA repair. They tend to show this single hit, single target cell survival curve. I'm not going to talk about the DQ. If anybody wants to ask questions about it, I'd be happy to answer it in an email, but I don't believe that those are so frequently, they're not used that much in today's world. Okay. Now let's look at modifiers of radiation. Here we're going to look at oxygen. So this is the log of the surviving fraction against the radiation dose again. Here are two survival curves, an aerated versus an hypoxic curve. Here we've got a cell line that has a curve that has a very low D0. Here we have a much higher D0. We pull out this lower part of the curve, and we see that these two spread out. What's the what we use then is an OER, which is the oxygen effect ratio that allows us to compare the hypoxic and aerated portions of the curve. It's the dose to kill cells under hypoxic conditions compared to aerated conditions. It is always over 1, or 1. 1 is the lowest OER that we can have, and the lowest OER we would have would be for high LAT radiations. We'll look at those in a moment. Here is the aerated versus hypoxic, and you notice that there is a difference in the dose for the OER. In this example, as the dose goes up, the OER goes up. When the dose is lower, the OER is lower. Here's a plot of the relative amount of cell killing that one gets following the oxygen tension. As the oxygen tension goes up, you would actually think, oh, oxygen goes up, and so therefore we should get more killing. But what actually happens is it plateaus. And it plateaus at around 20 to 40 millimeters of mercury, which is very near the oxygen concentration we find in venous blood. The 3 millimeters of mercury, or 0.5% of oxygen, is actually where the most dramatic increase is seen at these low oxygen concentrations. And so this becomes an important number. It's generally sort of at the halfway point. So it does go, the killing goes up and up with oxygen until it reaches the plateau at 20 to 40 millimeters of mercury. And you know, you can put in more oxygen all you want. It's not going to lead to that much more cell killing. So the amount of oxygen induced in cell killing saturates out. How does this affect us? It affects us when we're treating tumors clinically. Tumors have a necrotic core, and surrounding that necrotic core there are considered to be hypoxic cells. So if the tumor cord has a radius of under 160 microns, it does not seem to have a necrotic core and probably does not have many hypoxic cells. If the tumor cord has a diameter of radius of 200 microns or greater, it does have a necrotic center and likely has a hypoxic region. But if the cord has is between these two, it may or may not have a necrotic center. Now, I want to stress that what we're talking about here is a tumor cord. We're not talking about a tumor. And there are all these tumor cords that exist throughout the entire tumor, spread throughout. So each cord has this structure. This is not a single tumor that we're looking at here. Here again is a tumor cord. Here's the arterial end, the venous end, and the idea is that oxygen can usually migrate. There is an error in Hall's textbook that says 70 microns. The distance is 150 microns, and elsewhere in Hall it's actually corrected. This is a distance of 150 microns. Out here at this 150 micron distance is where we find the necrotic cells. Here is where we find the hypoxic cells at this region at the very end of the 150 microns. And very close, we find the highly oxygenated cells. What does this mean for us therapeutically? It means a couple of different things. Number one, go to irradiate this tumor cord, and what's going to happen? The necrotic cells are dead already, so who cares about them? The aerobic cells have lots of oxygen, and they have lots of glucose. They have lots of growth factors because they're close to the blood supply, so they're actually rapidly dividing. So they're going to be radiosensitive. Why? Because they have lots of oxygen and because they're rapidly dividing. What are going to be the problematic cells? It's going to be these hypoxic cells. The hypoxic cells are missing growth factors, they're missing glucose, and therefore they're going to be more resistant to radiotherapy, and they're going to be a problem for treatment. Okay, how is oxygen regulated? There's this, some people call it HPH. It's a prolyl hydroxylase. I think most people in literature would call it a PhD protein. This protein is an oxygen sensor. And when there's oxygen present, the HIF-1 alpha subunit of the HIF-1 transcription factor is the phospho groups on it are changed to hydroxyl groups. When the hydroxyl groups bind, the von Hippel-Lindau protein can bind to this, targets it for ubiquitination, sends it to the proteasome where it gets degraded. This is the process that's going on in all of our cells all the time. But when we have low oxygen, the PhD protein does not cause the phosphate group to become a hydroxyl group. So the phosphates stay on HIF-1 alpha. When it's phosphorylated in this way, HIF-1 alpha can bind to its subunit HIF-1 beta. When these two bind together, they can now bind to promoters of appropriate, they're appropriate, including the VEGF promoter. So the VEGF promoter gets turned on, and we have new vasculature that can result from the lack of oxygen. So this is the process that takes place, and it's from this HIF-1 hypoxia-inducible factor binding to the hypoxia response element on the VEGF promoter. Please do not confuse this with another set of H transcription factors, the heat shock factor binding to the heat shock element. Letters are almost the same on the HSPs, the heat shock proteins. A lot of times people confuse those, and they should not be confused. What's the relationship then between the OER and LET, and what is the relationship between RBE and LET? This curve, I think, is rather important and is one that I would probably try to remember. Here is the LET, the linear energy of transfer as it goes up. The RBE does go up, but not in a proportional way. It peaks at approximately 100, maybe a little more than 100 keV per micron. So down here we would have alpha particles and X-rays. Up here we would have neutrons. Over here we would start to find space radiation components at the far end. What's the OER that goes on with this? The oxygen effect ratio. As the radiation is going up in LET, the OER drops, but again, it does not drop proportionally. It drops in a very decisive curve, reaching its lowest point maybe around 120 or 150 keV per micron, about where we would find alpha particles hitting. But again, for OER, it does not reach 0, it reaches 1. It doesn't go below 1. So that means there's never a situation in which we can kill better with hypoxic conditions than we can in oxic. The best we can do is to have equal, and that's what we find from high LET radiations. Here are just some LETs associated with different radiations. photons and X-rays. We often talk about gamma rays and X-rays as if they're the same. They do have very different LATs, but if you'll recall from the previous slide, the RBEs are very similar. Here are electrons, here are charged particles, here are neutrons that have different LATs. And in fact, for some neutrons, there's actually a curve that tells us about that. During the cell cycle, the OER varies throughout the cell cycle. In G2 phase, the OER is actually lower than it is in S phase. In most examples, the OER is between 2 and 3. For any given phase of the cell cycle, the OER was the same for different doses in the cell cycle. And most often, there's not been shown to be a lot of therapeutic significance to this variation in the cell cycle. People have tried to take advantage of it, but they haven't been able to. What are these differences then between high and low LET radiation? We already said that most of the damage from high LET radiation is direct damage. Most of the damage from low LET radiation is indirect damage. The ionizations for high LET tend to be very dense. It's densely ionizing. They create blobs. For low LET radiations, it's sparsely ionizing. They create spurs. The survival curve usually has a steep slope, a reduced shoulder where the alpha is high, the beta is constant, and usually extremely low. The survival curve for the low LET has a smaller slope, a larger shoulder, and alpha is less important. Cell cycle effects are not so dramatic for high LET as they are for low LET radiation. There's been no sublethal damage or potentially lethal damage repair that's been identified for high LET. I think you could find some experimental data that would argue against that, but that's pretty much the norm throughout the literature. For low LET radiation, there are obviously both kinds of repairs. The one that is probably of clinical significance most to us, of course, is sublethal damage repair. And I need to say right now that some people call this sublethal damage repair, and that gets people confused with DNA repair. In fact, probably a more accurate term would be to call it sublethal dose recovery, because it's about the recovery of the cell from the radiation injury, not about repair. The OER for high LET, there's not much of an oxygen effect. We just saw that a moment ago, where it for low LET radiation, oxygen enhances the effects. For radioprotectors, it's still questionable, but most radioprotectors do not seem to work well with high LET radiation. They do work well with low LET radiation. So then if we kind of look at these radiation damage categories, of course there's lethal damage, which is totally irreversible, not repairable, and it's going to lead to cell death. There are going to be two kinds of damage that can be repaired. One is the sublethal damage repair, which is generally repaired in hours. Most people would say in culture it's about 2 hours. If a second dose is given, they can interact, and it usually represents the shoulder in the survival curve. We define sublethal damage repair, or as I would say recovery, as the increase in survival when a dose is fractionated over time. Potentially lethal damage can be modified by the post-radiation environment. And what that would mean is you put the cells in any conditions that are suboptimal for growth, and such as without serum, without growth factors, in a density inhibited state. All of those would lead to potentially lethal damage repair. What about the dose rate effect? Here are survival curves for HeLa cells, log of the surviving fraction against radiation dose. What you would notice here is that when you give a dose rate of 7 and 1 gray per minute, you see these curves are very similar. When you go way down to 0.5 centigrade per minute, you see that this curve gets pulled out and gives improved survival. So as you decrease the dose rate, the survival curve tends to be more shallow, the shoulder disappears. And where a lot of people would claim that the dose rate effect is most evident is between the doses of 0.01 and 1 gray per minute. That's where we start to see this. So down here at the 1 to 7 gray per minute, we're not seeing a big difference. But here at the 0.01 to 1 gray per minute, that's where we see a demonstrable difference. It does vary from one cell type to another. And in fact, there is the example of a dose of an inverse dose rate effect, where at least a few cell lines show that more sensitivity at low dose rates than at high dose rates. So that inverse dose rate effect does exist for a subtype of HeLa cells and a few other cells. The most important FDA-approved radioprotector. It's used clinically, although I will argue it's not used that frequently, is amifostine. I think amifostine becomes important because it tells us something about mechanisms. The drug that we give to patients is, and it's mostly, I think, for salivary gland tumors nowadays, is WR2721. In vivo, it becomes WR1065. These were developed by Walter Reed, which is how they got their name. If you were to work only with cells in culture, you would use WR1065. What happens to WR2721 in the patient or in the animal? It is a prodrug, and the drug is modified by the liver, the alkaline phosphatase. It takes the phosphate group off the drug, makes it become the active drug in the body. There is better transport of the drug to normal tissues than there is to tumor. So particularly at early times after exposure to the drug, we find normal tissues are protected, whereas the tumor is not protected. So therefore it should be used before radiation exposure. It gives really good protection for hematopoietic system, gut lining, and salivary glands. Really no protection for the CNS. It doesn't cross the blood-brain barrier. It is hydrophilic in nature, which is probably what's responsible for its increased uptake in normal tissues. But there is a dose-limiting toxicity that a lot of people choose and prefer not to use it. It's hypotension. It's also called ethiol, and as I said, it's FDA approved for treatment. Here's just the structure of amifostine. Right here, you can see this phosphate group right here that allows it to be degraded in the liver and therefore become the active drug. Now, I need to say that a lot of radioprotectors and radioprotective compounds have a sulfhydryl group on them. If you see a free sulfhydryl group on a compound, you can pretty much assume that it's going to be a radioprotector. Perhaps not a great radioprotector, but we should be able to scarf up those hydroxyl radicals and neutralize them, and that's what this drug is thought to do. I will mention that in context, there are some other drugs that are worth talking about. 5-bromodeoxyuridine is shown here. It is a halogenated pyrimidine. It's used in chemotherapy. It is a radiosensitizer. It has some side effects, and that's why it's not often used. And it's got a second use, which you should be aware of, and that is it's actually used to label cells in culture and in animals to tell us about the cell cycle. So it was developed, it's used as a chemotherapeutic agent, intercalates in the DNA, makes it be a radiosensitizer, but it also is used from a methods perspective in measuring the cell cycle. Misinidazole is a radiosensitizer that works for hypoxic cells. It's probably not used as much clinically anymore, but where it becomes important is in marking hypoxic cells. A lot of times there's like F-MISO, which is used for in PET assays to tell us how much hypoxia we have in tumors. It was developed as a radiosensitizer of hypoxic cells, but it's a great marker for hypoxic cells. And finally, there's another response modifier I want to mention, which is tirpazamine. It is not really a radiosensitizer in any way, but it works synergistically with radiation. It is a bioreductive drug. It is toxic for hypoxic cells, and therefore could have some use. The law of Burgundy and Truffaut, I don't want you to think that all cells are equally radiosensitive. The idea that they originally came up with was that radiosensitivity of a cell line varies directly with its rate of mitosis, directly with its mitotic future, and indirectly with its degree of differentiation. What does that mean? That means the most radiosensitive cells are going to be cells that are dividing and are not differentiated, and the most radioresistant cells are going to be cells that are not dividing and are fully differentiated. So stem cells are going to fit into this highly radiosensitive category. Neuronal cells are going to fit into this highly radioresistant category. But clearly, you should know that the most radiosensitive cells in the body are lymphocytes. They are very, very radiosensitive, but they fit into this category of going through the body. Not if they haven't encountered antigen, they do not divide. So they actually don't have a great mitotic future. They can be stimulated to divide. They're actually fixed post-mitotic cells. What does this mean? This was a formulation that was divided by Casaret, among others, and they divided up cells by cell type into the examples of each. And as I just said before, these stem cells, erythroblasts, cells that are crypt cells, germinal cells of the epidermis. These are going to be what are the so-called vegetative intermitotic cells. What matters is they divide. They're poorly, they have little, if any, differentiation, very radiosensitive. At the other end of the spectrum are these fixed postmitotic cells, nerve cells, muscle cells, very low. In between are going to be the myelocytes, which differentiate connective tissue, and then these so-called reverting postmitotic cells, which don't divide, but you can stimulate them to divide. Liver fits into that, right? It's sort of one of those cells that it regenerates, but only if you cause injury. And again, please remember, lymphocytes are the exception to this pathway. They have a very low D0, even though one would probably put them in this reverting postmitotic category. Okay, we're moving now from what we know about cells to moving up to whole organisms, people, based on radiation accidents and total body exposures. We can look at the acute effects of radiation, and this is from a total body exposure in most examples. And these are the three modes of cell death, or body death, person death, that would occur. Hematopoietic syndrome normally is a latent period of 2 to 3 weeks. The dose range is 2.5 to 10 gray. We give this in gray because they are deterministic effects. Stochastic effects tend to be given in sievert. The deterministic effects tend to be given in gray. But what we'd say is this is gray equivalent in gamma rays, and we would have to scale it down for the dose that we would expect in neutrons or alpha particles or some other exposure. What's the underlying cellular effect? Necrosis of the bone marrow cells. During the prodromal phase, we can expect anorexia, nausea, vomiting. During the principal phase, we can expect to have petechiae and purpura. There's going to be some bleeding from mucous membranes, and we're going to have infections start to set in. This is going to lead to death in 2 to 3 weeks after the exposure. And what we would find at autopsy is that the cells in the bone marrow are missing, and that there's evidence of bacteremia. The next highest dose syndrome, this time at a dose of 10 to 50 gray, is the GI syndrome. Latent period is 3 to 7 days. This time we're going to find death of the mucosal stem cells in the gut. So again, we have stem cells. In the case of the hematopoietic cells, it's the bone marrow stem cells. Here in the GI syndrome, it's the gut stem cells. Anorexia, nausea, vomiting again, but this time principal phase is going to be fever, bloody diarrhea, loss of fluids and electrolytes, death in 5 to 12 days. And we're going to find at autopsy that the cells in the crypts have undergone mitotic arrest, and that there are confluent intestinal mucosal erosions. In the highest dose syndrome, which has many different names, some people call it CNS syndrome, some people call it acute incapacitation syndrome. This is going to lead to death in 15 minutes to 3 hours. The lethal dose range here is 50 gray or higher. The underlying cellular effect, there aren't that many patients that have undergone this, but most people would say it's due to both endothelial cell damage, which is going to affect blood vessels, of course, and death of neurons at the very high doses. We're going to have nausea, vomiting, but now we're going to have anxiety, confusion, ataxia, apathy. In the principal phase, it's going to be apathy, lethargy, somnolence, tremors, convulsions, and coma. I don't think this table is correct. I think that the time to death should be listed as 10 to 49 hours, since at least a couple of patients recorded in the open literature made it to 48 or 49 hours. At autopsy, we would see that there's evidence of increased intracranial pressure, microvasculitis, and necrosis of isolated neuronal cells. Now, while I think this chart is worth knowing. I think it's also important to understand it in its context. So, you know, if somebody were to ask you about, you get exposed to a dose of, you have an unknown dose that the person was exposed to, they are experiencing apathy, somnolence, tremors, which of the following doses would they likely receive, you would know that that's in the 50 gray range and not down here at the 2.5 gray range. So I think the application of this table would be very important for the entire radiation world. Where are bone marrow transplants, and what do we consider the right doses for people? We usually look at two different LD50s for people. We say that the LD50 for patients with no antibiotics and nursing care, which we learned from the Hiroshima Nagasaki case where there was not much medical intervention in those patients. The range is normally between 2.5 and 4 gray, depending on which population you look at. But that's the LD50 with no treatment at all. If we just give antibiotics and nursing care, that is, throw the person in the hospital, treat them well, and give them antibiotics, we can push the LD50 for humans up to 7 gray. At what point in time do we consider bone marrow transplants? This is extremely controversial. The answers in Europe are different than the answers in the U.S. I believe most people would say that it's in the neighborhood of 7.5 to 8 gray is where we would think about a transplant. Of course, if the person has bone marrow stored and it's their own bone marrow, there would not be a risk. What the risk is graft versus host disease. If the person has a little bit of bone marrow left, if they had partial shielding and we don't know it, then graft versus host it can be very likely in a radiation accident, and that's what created some problems in Europe. Okay. Exposures of a pregnant mouse or person to radiation, what do we think will happen to the fetus? We know that there is a period that we would call the pre-implantation period, which is at the highest risk for prenatal death. In mice, we assume that the same thing happens in humans. During this period of organogenesis, which is in the human from about 10 to 41 days after conception, this is where we're going to find abnormalities of a structural nature. We might find neonatal death resulting. We are not going to see that much. There will be a little bit of prenatal death. This is not to say that in the fetal period beyond 41 days there are no effects. We just see different effects there that I'll talk about in the very next slide. So this is one understanding of it. So as we saw right from pre-implantation, there's the prenatal death. From the organogenesis, we expect congenital abnormalities that are structural in nature, some neonatal death. And now we expect to also see some growth retardation. In the fetal period, we would see permanent growth retardation. What do we see from the only humans that have been exposed in utero came from the Japanese atomic bomb survivors. There was a neonatal, prenatal and neonatal death that occurred in the up to the first 4 weeks. We assume that there is a microcephaly and general growth retardation. I would actually remember that from 8 to 15 weeks is a period at high risk for mental retardation. That risk is 40% per sievert. The risk goes down tenfold from 15 to 25 weeks, and that risk is 10% per sievert. So the idea is that we don't know this risk of prenatal and neonatal death. We assume it from the animal studies, but the rest of these we actually have data from the Japanese atomic bomb survivors, particularly for the mental retardation and the higher and lower risk. Now I need to say this, is this risk a stochastic or deterministic effect? It is a deterministic effect because it is damage to the developing fetus that is developing. The only example of mental retardation that would be considered to be a stochastic effect would be if there were a mutation in either the mother's eggs or the male's or the father's sperm that led to mental retardation. So that distinction I think is important to remember. Okay, here is the story of the male versus female reproductive systems. The male system has this spermatogonia to spermatocytes to spermatids to spermatozoa. So it has this development that's occurring. So therefore, what's going to be the most radiosensitive? It's going to be the stem cells, the spermatogonia. And the mature spermatozoa are going to be very radioresistant. So therefore, one can expect a latent period between the time of radiation and the induction of sterility. Why? Because as long as there are mature sperm floating around, he is still fertile. When it comes time for the spermatogonia to give rise to the spermatozoa, and there are no spermatogonia there, that's when there's a problem. The dose for low sperm count and reduced fertility is 0.15 gray. For no sperm count and temporary sterility is 0.5 gray. The recovery is 1 year after a 2 gray exposure. And the testis is interesting because it is a dose rate sensitive tissue. Permanent sterility is 6 gray for a single dose, but for a fractionated dose, it's only 2.5 to 3 gray for 2 to 4 weeks. This is important if you think clinically about treating, say, a testicular cancer in a 18-year-old man. Induction of sterility does not affect hormone balance, libido, or physical capability. Let's look at the female. This is the exact opposite situation. There is no development that occurs in the ovaries. By 3 days of birth, she has every egg she's ever going to have. You irradiate, you leave one egg, she is still fertile. If you take away all the eggs, she is sterile. So at 3 days after birth, all the cells progress to the oocyte stage. There's no further division. Therefore, there is not a latent period in the female, and there is no dose to induce temporary sterility. Radiation can cause permanent ovarian failure. Permanent sterility is 12 gray for a prepubescent girl, 2 gray for a premenopausal woman, and it produces the same changes that those are seen in natural menopause. Now, I mentioned some of these numbers. I want to mention a few others. Severe mental retardation, we just said, is 40% per sievert, goes down to 10% per sievert at 15 to 25 weeks. For the general population, carcinogenesis risk is 5% per sievert for low dose re-exposures. We're going to talk about that in just a little bit in more detail. The hereditary effects to the general population is 0.2% per sievert. Okay, many people divide tissues up into hierarchical and flexible type tissues. So what we're looking at is you irradiate an organ system, and how can you expect it to respond to radiation? Let's look at the hierarchical first because it's the easiest. What fits into hierarchical tissue? These are tissues where you have one cell type that differentiates into another cell type. These, when you irradiate them, the latent period is the same regardless of the dose. If the dose is high enough, you can get total failure. If the dose is large, the response takes longer to recovery. If it's small, it takes a short time to recovery. And the dip into the mature pool is small for a small dose and large for a high dose. Flexible type tissues are very different in this response. They tend to have much greater volume effects with them. You irradiate, and if you give a large dose, the dose to induction to the latent period is shorter than it is for a small dose, but the recovery time is faster for a large dose than it is for a small dose. Why is that? Because the radiation is stimulating more cells to go into division and to respond properly. So therefore, when you give a higher dose of radiation, you decrease the latent period, you get a better response, and you get a faster response back to normal. So as I said, these are organ systems, like the kidney and others that have like very have volume effects. What about radiation and the immune response? A couple of main points I want to make here. Macrophages are extremely radioresistant. They're probably the most radioresistant cells in the body. They can resist up to 100 gray if you give them. Now, radiation does activate them, but they are very radioresistant. Let's look at B cells and plasma cells. B cells are very sensitive. Down to 80 centigrade, they're probably the most radiosensitive cell in the body. Plasma cells, which remember are the mature B cells that have already responded to antigen, are stimulating tons and tons of antibody, those are pretty resistant, 60 to 90 gray. What about T helper, T suppressors, T cytotoxic cell types? The T helper cells are the most radiosensitive of the T cells, 1 to 2 gray. T suppressors are next at 1 to 5 gray, and T cytotoxic at 2 to 5 gray. They're all pretty radioresistant at 10 gray. So just look at this picture for a moment. You go to irradiate a patient that has, we're going to give a person a radiation response. Are the plasma cells, is B cell immunity going to be affected by radiation very much? At a 60 to 90 gray sensitivity, probably not. We're going to keep B cell immunity intact. So if the person was immunized with a vaccine, they're probably going to be okay. And even the 10 gray, they're going to be likely to be okay. We might not want to give a vaccine during the course of radiotherapy because we want to get the maximum response that we can. We might not even want to give it early because there might be a lot of cells that are developing from B cells to plasma cells, so we might not want to give it for the first few weeks before radiation exposure. But the immunity they received as a child probably is not likely to be that much affected by radiation exposure. Granulocytes are resistant, NK cells are resistant, and again, the precursor cells are very radiosensitive. Here is the response from for early responding tissues and late responding tissues, we know that we can divide tissues up into those that respond early following ionizing radiation and those that respond late following ionizing radiation. The early responding tissues often respond during the course of conventional therapy. Often late responding tissues respond later, and so therefore we must take that into consideration when we're giving treatment. The early responding tissues respond within the first. They're just defined actually based on how early and how late they respond after radiation exposure. So that's how they got their name. It's just logical. The dose responses look different for early and late responding tissues, and this is very important for us. Here's log the surviving fraction against dose. I want you to notice that not only do these curves look different, but the shapes are actually different. So here's the late responding tissue. Here is the early responding tissue, and please note the tumor responds much like the early responding tissue. What you should see is at low doses that the early responding tissue tends to be more sensitive. At high doses, the late responding tissue tends to be more sensitive, and this is going to lead to differences in what happens when we fractionate, which is one of the most important distinctions with early and late responding tissues. The alpha-beta ratio, and we defined the alpha-beta ratio already. The alpha-beta ratio is 2 to 3 for late responding tissues. It's near 10 for tumor and early responding tissues. So what we would say then is that for late reacting tissues, fraction size dominates the late effects. The overall treatment time has very little influence on it. For early reacting tissues and tumors, fraction size is important, but overall treatment time is also important. So this curve is an isolated effect curve, and this curve is very important to understand. I want to point out a few things. First of all, the total dose to achieve a type of iso effect is shown on the y-axis here. The dose per fraction, but we're going from high to low dose per fraction. If we were going for total doses, we were going from low to high here, but we're going for dose per fraction. So we're actually looking at how a tissue responds to a fraction. And what has happened here is that in this particular diagram, the way it's set up, this was done by Rod Withers a number of years ago, and what was done in order to make this easier for us is that the acute reacting tissues are shown in blue, and the late responding tissues are shown in this kind of brownish red color. And so what you should notice right away is that the iso effect curves are steeper for these late effects than they are for the early effects, which is shallow. What does this mean? This means exactly what we just said a moment ago, where the fraction size is going to be very important for the late effects, but the fraction size it is not going to be so important. It's only somewhat important for the early effects. So this dose per fraction response is really critical. It's critical for us in understanding how a treatment regimen is going to work. Okay, human population exposures. Japanese atomic bomb survivors are the most important group for determining our risk estimates today. 120,000 people were exposed. They were followed throughout their entire lives. They were exposed to neutrons and gamma rays. Precise dosimetry has been used, and it makes us understand the increase in risk estimates of cancer. Another population that's important is the ankylosing spondylitis population. These patients were often given X-ray therapy to the spine. They developed a higher incidence of leukemia because of it, and radium salt injections were given, and the radium, of course, homes to bone, and it gave them bone tumors. There were some patients, mostly young patients, where they thought a large thymus was going to cause asthma problems. They gave them a radiotherapy dose to the thymus. Thymus is the most radiosensitive organ in the body. What's in the field, the thyroid's in the field, and it led to an increase in thyroid cancer. In 1940s in the U.S., people with big adenoids and tonsillitis were treated not with surgery but with radiation, and those patients had a higher incidence of thyroid cancer. And even if one anecdotally, I've been hearing in the literature in the clinics that they also tend to have some meningiomas. There was a large cohort of tinea capitis patients in Europe recently studied, in North Africa that moved to Israel a little bit older studied. They would give them an X-ray dose to the scalp to eliminate this fungus, which was very debilitating, very painful. And what's in the field then, the thyroid and skin, and so they went on to develop thyroid and skin cancer. The European experience was that they also had meningiomas, some brain tumors, some leukemias, and some salivary gland tumors. I believe the doses there were a little bit higher than the American experience, which was mostly thyroid and skin cancers. I should mention that there's a registry in the U.S. at the University of Rochester still for these patients, for the tissues from these patients. Fluoroscopy was used for TB patients. The doses were pretty high for what we do. They had an increased incidence of breast cancer. Thorotrast was this amazing contrast medium. It was amazing because it had radioactive thorium in it. They would give these to patients. The thorium would go right to the liver, and they would get liver tumors. And then finally, even today, we treat some peptic ulcer patients with radiation to try to eliminate the peptic ulcer. If the dose is under 10 gray, they're at higher risk for developing stomach cancer than they are otherwise. There are also occupational exposures. Early radiologists would put their hands in the beam to try to calibrate. They didn't know all the risks. Dentists would put their hand, they would hold the X-ray film in the mouth of the patient and then clip an image. They end up developing higher incidence of skin cancer from it. Lung cancer popped up in uranium miners and radium miners, but I need to say that this was actually a lot related to smoking as well. In fact, if they had smoking and radium exposure, they had a way higher incidence of lung cancer than if they did either one alone. Radium dial painters were painting watch dials onto they were painting watch dials using radium to make watch dials appear to glow in the dark. So they're painting radium on it, and what they would do is lick the tip of the paintbrush, ingest radium in the process, and they ended up getting bone tumors because the radium homed to bone. And then finally, before the 1920s, some radiologists and people that were giving radiotherapy, again, unaware of the risks, developed leukemia. But these patients, both the occupationally exposed and the population exposed groups, have helped us to understand radiation-induced cancers. And what we can summarize from that, in addition to some recent studies, is as follows: that there is a latent period between the exposure to radiation and the appearance of malignancy. Leukemia is the earliest one to pop up. It begins at 2 years, and some people would even claim it begins at 1 year following exposure. It peaks at 7 to 12 years, and then, interestingly, it goes away at 20 years. Thyroid tumors appear to be somewhat different from all other solid tumors, but most of those pop up from an internal exposure to iodine. The solid tumors, in this instance, the person from Chernobyl, for example, or from nuclear fallout was exposed to radioactive iodine. It homed to the thyroid. The incidence, most of it started around 4 years after the exposure. It peaked at around 7 to 10 years, but it has not come down. For Chernobyl, we're still seeing that they have an increased incidence over background, and particularly if they were exposed when they were young. I'll mention that in a moment. For other solid tumors, the early reports tended to be that they started around 20 years after exposure, but I think the data now are pointing to a much earlier, maybe 12 years after exposure. The latent period is affected by the age the person is at exposure. I'll show you that in a minute. And the age at which the tumor is often expressed. You're not going to see a breast cancer, for instance, popping up in a young girl. You're going to see it popping up in a person that has all the hormones that would allow the breast to develop. Now, one of the biggest controversies, I think, that has existed in radiation biology, at least, has been what is going on between high dose rate and low dose rate exposures. So this is a plot of the cancer incidence against dose. Here we have the actual data, say, from cancer incidence from Hiroshima and Nagasaki. And what we do is we predict a linear non-threshold response in the U.S. as being the best means for radiation protection. Nobody says this is how the biology works, or maybe a few do, I don't know. But most people say that's not how the biology works, but this is what we use for radiation protection. It's the safest. It keeps people safe. It's based on data here at the higher doses we don't have low-dose data to be able to confirm this. There are some studies now that are getting down a little bit lower, but still not great. The problem is that the low-dose rate is the hard part. And what are our exposures occupationally, environmentally? They're all low-dose rate exposures. So being able to predict what this low-dose rate would be really important. What do? We say animal data showed us that it was low-dose rate. So therefore, we're going to say that the low-dose rate exposure is half the risk of cancer as the high-dose rate exposure. Lots of people are working on this. There are a number of population studies that are being done. We may see some differences and some shifts in this model, but it is extremely controversial right now. I think for now, you should assume that this chart is correct, and low-dose rate exposure is half of the high-dose rate exposure. What then was done is there were some numbers given on risks from radiation exposure. I'm not sure I believe that these numbers are highly accurate, but I'm going to tell them to you because most often you need to have access to these numbers. So this was developed by the ICRP in 1990. I'm a member of the ICRP, and we discuss these numbers all the time. What they said at the time was that if a population receives a high dose rate exposure, and they are a working population, they would have a risk of developing cancer of 8% per sievert. If it is a whole population, like the city of Chicago here, the risk would be 10% per sievert. So a working population would be the people working in the nuclear department in a hospital or a nuclear power plant or something like that. The whole population would be 10% per sievert. That's the city. Why did they distinguish between these two? Because they said, that you are probably working only 8 hours a day and therefore have less exposure as a working population than you have at home as a whole population. We might disagree with that, but that was the decision made at the time. Probably applies to most nuclear workers, actually. Okay, so this was the high dose. Here's the low dose rate, and they used as their cutoff less than or equal to 0.2 sievert. And what they said was, for the working population, we're going to take the high dose rate, and we're going to make it be half. It's going to be 4% per sievert. And for the whole population, it's going to be 5% per sievert. So, the ways in which people think about this is they're like, okay, there was a nuclear power plant of 4,000 people. They were exposed to 0.1 sievert. How many excess cancers do you expect? And what you think in your head is, okay, first of all, it's a nuclear power plant, it's 0.1 sievert. I'm going to use this 4% per sievert number because it's working population and it's low dose rate. But this gives you 4% per sievert. I just said that the exposure was 0.1 sievert. So it's going to be 4%. It's going to be 0.1 of 4%. So it's going to be 0.4% of your population of 4,000 people. So that's how you would do that kind of calculation. Again, I don't think this is so useful, and there are a lot of people that argue that these numbers are not accurate, but they're generally worth knowing, I think. So this is the new chart from Hall and Giaccia. I want this to be clear to you that there's one number that has changed here. So if you learn the old numbers, you got to know the new numbers, and I believe the new ones are the most accurate. So for occupational exposures, your exposures as you're working are 10 millisieverts times your age. And please, we have to know the ICRP numbers, the NCRP numbers, the National Council on Radiation Protection. I'm a member of this. You need to know these numbers, not the ICRP numbers, which are the International Commission. I'm also a member of that. But NCRP numbers are what we need in the U.S. So the dose for the effective dose limits for cumulative is 10 millisieverts times the age, or annually 50 millisieverts times the age. We also do some for deterministic effects, and this is where a mistake is made, where we talk about exposures in sievert for deterministic effects. Everybody knows that this is wrong, but they still continue to do it. It should be in gray, not in sievert. But okay, lens of eye changed, and you can see that there's this typo here. Nobody caught this because it's new. It is now 50 millisieverts per year for occupational exposure for lens of the eye. Why? Because there was a committee, I was on it, that said that the risk of cataracts is greater than we thought it was, because we can detect with greater sensitivity cataracts than we ever could before. The limits are 500 millisieverts per year for skin, hands, and feet. The embryo and fetus exposure in the U.S., we look at the dose to the pregnant mother. not the dose to the fetus, the embryo and fetus as they do internationally, but to the dose to the pregnant mother. Why? Because we can measure it. And we say it's 0.5 millisieverts per month or 5 millisieverts for the duration of the pregnancy. When does this dose begin? It begins the day pregnancy is declared, usually in writing. So let's say you have a pregnant worker who's working with you. She is obviously pregnant, and she has not declared her pregnancy. What is her dose? Her dose is up here at the occupational exposure. It only goes down to the effective dose limit of 0.5 millisieverts per month after the pregnancy is declared. So then, do you then go back and calculate, oh my, she didn't declare for 6 months, so she was exposed for all those 6 months. What was her exposure? No. This dose limit comes into effect only the day the pregnancy is declared. Now, what do you do when a pregnant worker comes up to you and says, I'm pregnant, or sends you it, writes it in writing, which is the best way to declare it? You cannot say, oh, you can't work with radiation anymore, or go sit at the office and work for a week. No, for your 9 months. What you do is you say, you must work to reduce your dose exposure. You might want to wear 2 aprons. You might want to limit your time in doing brachytherapy. I mean, those are the kinds of things that can be done, but you can't. It's actually illegal to stop somebody from doing their job. Okay, here are the dose limits for the public. Here are the dose limits for education. Not much difference between these. Who fits into education? Actually, your medical students fit under education. They are not occupational. They're not being paid. They're paying their education. General public, notice 1 millisievert per year for continuous or frequent exposure. There is a 5 millisievert per year for infrequent exposure. This is permitted at some sites where a person might go once a year. And the negligible dose is 0.01 millisieverts per year. So these, and I would know these, I think that these are important to know. No, I did promise that I was going to give you, and I'm sorry for the, I work at a hospital, you can hear the background. Here are the dose ranges. This chart I think is extremely useful. This is put together by Noel Manning, a friend of mine at DOE. And what Noel did is she took the medical diagnostics in milligray for exposures for X-rays, imaging, CT scans, and fluoroscopy. These numbers are actually extremely useful. Knowing what a mammogram is, for instance, is as 2 to 4 milligray. Being able to know that a barium contrast is 10 to 22. Those I think are extremely useful. What else this chart does, it's actually useful for pointing out to patients, but there's some numbers in it that you might find useful too. It goes in orders of magnitude. So here's the 0 to 1 millisievert, 0 to 10, 0 to 100, 0 to 1,000, 0 to 10 sievert, and 0 to 100 sievert. And of course, we in radiation therapy, we live up in this upper range, but that's the dose only to the tumor, not to the total person. Acute radiation syndromes are in this 0 to 10 sievert range, and we can find different types of onsets for LD50. They actually have listed here the erythema reactions and ablation. Those numbers are probably worth looking at as well. The cancer epidemiology is 0 to 1,000 millisievert. 0 to 100 is what Department of Energy is interested in. 0 to 10 is where we find medical diagnostics, which is in that chart. And 0 to 1 millisievert, which is where our regulations and guidelines put us. So I think this chart is extremely useful. There's a lot of really important information. Okay, we're now going to jump, and we're going to jump from talking about cancer and radiation protection at low doses to now talking about molecular cancer facts. I cannot tell you everything you need to know. I'm going to point out some of the highlights, but it's the best I can do. Here is proto-oncogene. The proto-oncogene can become activated by retroviral integration, by development of deletions and point mutations, as we see in some of the RAS, by gene amplification, which is where we get many copies of a gene, and by chromosomal rearrangement, like that translocation that we talked about earlier. Retroviral integration does not seem to happen that much for human situations. Happens much more in animals and chickens and species like that. Point mutation deletion can happen. We know it for RAS, where a mutation from glycine to valine at amino acid 12. And there's another one at 61 and another one at 13. If those changes take place, the protein levels remain about the same, but the protein is now more active than it ever was before. Gene amplification is where you go from having 2 copies of the gene in the cell to having zillions of copies of gene in the cell. And then there are chromosome rearrangements where you take a gene that's probably in a pretty silent location of the genome and put it in a very active situation. Here are a listing of some of the oncogenes that are associated with deletions or translocations and some of the tumors that are associated with them. I would certainly understand some of the oncogenes versus tumor suppressor genes as being important here. RET oncogene is associated with thyroid cancer. That's become important. Or B with head and neck. And then here are some of the tumor suppressors: RB, Wilms tumor, and neurofibromatosis 1, familial adenopolyposis, P53, and disseminated colon carcinoma. I would be able to recognize that these are tumor suppressor genes versus these dominant oncogenes that are shown here. It may also be important to know some are activated by gene amplification. That would be important. There are tons of things about P53 that are important. I wish I could tell you everything you need to know about P53. I'm going to do my best to highlight some of those points now. It is a tumor suppressor. It's lost or inactivated in well over half of human cancers. It is activated by damage to DNA. So P53 itself is not a DNA repair protein, but when it is activated, it turns on a bunch of DNA repair proteins. If you damage the cell in G1, it will lead off into G1 arrest, which is regulated by P53 almost exclusively. Damage during G2 can lead to apoptosis regulated by P53, but it can also lead to CHEK1 and CHEK2 being activated. We'll mention that in a minute. P53 binds to promoters. It is a transcription factor. It binds to promoters that contain a 20 base pair recognition sequence, and by doing so, it activates a bunch of different genes. Among the most important that I would be aware of are P21, MDM2, GAD45, proliferating cell nuclear antigen, PCNA, BAX, NOXA, PUMA. Notice that some of these are involved in apoptosis here. GAD45 got its name. It's involved in DNA repair. PCNA is important in cell cycle regulation and in repair. MDM2 actually degrades P53 itself. It can bind to some single-stranded regions in damaged DNA as well. And you need to be aware that there are multiple ways of inactivating P53. One is you can inactivate P53 directly. You can actually put a point mutation in the P53 part of the transcription factor that binds to its transcription elements and can't turn on these genes. That's one way to inactivate P53. The second is to have mutations in other loci that lead to a loss of P53. And among those loci are this INC4A ARF locus, which the INC4A encodes P16. That controls RB. P19 controls P53. This locus is a single locus that regulates 2 different genes. So now you take out this locus, which is commonly deleted in some cancers, and you've inactivated both RB and P53 in one fell swoop. So this is a means of regulating P53 without doing anything to P53. Another means is these viruses. There is the E6 protein of human papillomavirus, the adenovirus E1b protein, and SV40 large T antigen. All 3 of these can bind to P53, tie it up so that it cannot bind to its transcription factor. So if you were to sequence P53, it would be perfectly normal. But guess what? If it's got these viruses in, then it would not be able to function. So in cervical carcinomas, where HPV is very commonly 90–95% present, P53 is not mutated in those cancers, but it is inactivated by the E6 protein. P53 is destabilized by MDM2, which targets it for degradation, and it is modified by phosphorylation or acetylation in response to damaged DNA. Here are just a partial list of the genes that are affected by P53, WOF1 CYP, EGFR, RB, PCNA, GAD45. I mentioned some of these BAX, PCNA, GAD45 I already mentioned. Some of them are involved in cell cycle regulation, some are apoptosis, some are in DNA repair. Now, I actually like this diagram done by Shirley Leonard on cell cycle regulation. What this shows is the M to G1 to S to G2 to M transition, shows the different cyclins, D, E, A, and B cyclin that are coming up. The cyclin-dependent kinases that phosphorylate these, so it's CDK4 and 5 phosphorylate D, K2 phosphorylates E, and K1 phosphorylates A and B. It also shows proteins that block this process. So notice that the P16, which we just mentioned a moment ago as being encoded by the INK4A locus, this blocks the M to G1, and then we have these other proteins that are going on here as well that are blocking it, and then we have the CDC and the CIK proteins that are regulating the cell cycle. This is probably one of the better analyses that I've seen. I also want to point out that we can find radiation-induced cell cycle checkpoints at G1, S, and 2 in G2 that are well known. The check proteins, and this should actually be check 2, not check 12. Check 1 and check 2 regulate S, early G2. Check 1 regulates late G2. So this would be important to understand. I'll also mention now, and we'll talk about later, ATM proteins are going to be very important in DNA repair, but they phosphorylate P53, the check proteins. Therefore, ATM regulates these cell cycles as well. ATR, the AT-related protein, works predominantly in G2, in late G2. This now shows apoptosis. This shows at least two of the pathways, with the so-called intrinsic pathway and the extrinsic pathway. The intrinsic pathway involving ATM, phosphorylating P53, affecting the mitochondria, that then release cytochrome C, convert procaspase 9 to caspase 9, activate 3, 6, and 7, and lead to apoptosis. Or the external pathway, where we have a ligand binding to a receptor. This example is showing Fas ligand binding with Fas, but it could be TNF binding to its receptor, releasing caspase 8 from procaspase 8, leading again to this very same pathway and turning on 3, 6, and 7. And the caspases are shown here with their various different interactions. I want to point out a couple things. 9 regulates 3 and 7. 3 regulates 6 as well. And these all carry out a variety of functions. Caspase 7 regulates PARP, which is involved in DNA repair. Why do you want to repair DNA if you're going to die, right? If the cell's going to be apoptosing, then you want to turn off repair. DNA PKCS is regulated by caspase 3. It's going to be involved in DNA repair. 3 regulates the DNA fragmentation. And the lamins, which are involved in the cell as it shrinks undergoing apoptosis. There is a third pathway of apoptosis, which is not always mentioned in most textbooks, is mentioned in most radiation textbooks. It's the sphingomyelin pathway. Radiation turns on the acid sphingomyelinase, which now changes sphingomyelin to ceramide, which activates caspase, and in particular works on endothelial cells to lead to tumor damage and tumor response. So this pathway is also very important. Now, I want to mention, sorry, I'm trying to catch with everything. I want to mention the NF-kappa B pathway because I think that this is also critical. Here is with TNF-alpha, but there are a few things you need to know about NF-kappa B that would be important. NF-kappa B, so we just talked about P53 being a transcription factor that turns on a whole bunch of radiation response genes. NF-kappa B does as well. And what I think would be important here is that NF-kappa B is a dimer. It binds and lives in the cytoplasm bound to its inhibitor, I-kappa B. I-kappa B is phosphorylated by a protein called I-kappa kinase. When this I-kappa kinase phosphorylates I-kappa B falls off the NF-kappa B dimer, can now move into the nucleus, bind to its NF-kappa B response element, and turn on a whole bunch of target genes. This usually happens at slightly higher doses. One would see this happening at like maybe 5 or 6 gray. I'll actually show you a chart with that in just a moment. But this so P53 is regulated by being phosphorylated. This is NF-kappa B is regulated by phosphorylating its inhibitor. So it functions in a slightly different way. Now, I need to mention some specific cytokines that in particular are regulated by NF-kappa B. Not all of these. Basic fibroblast growth factor is not regulated by NF-kappa B, but it increases growth of endothelial cells, inhibits apoptosis, protects against microvascular damage. Platelet-derived growth factor increases damage to the vasculature. TGF-beta increases inflammation, decreases growth to the connective tissue. You'll remember TGF-beta because it's extremely important in fibrosis. And one thing that I like to remember is that TGF-beta, unlike epidermal growth factor and TGF-alpha, it has two different types of receptors for signal transduction. That is, it's a dimer that's a heterodimer. It's made up of two different receptors, whereas TGF-alpha and EGF receptor are homodimers. TNF, IL-1, and IL-6 are all turned on by NF-kappa B. TNF is part of the inflammatory response pathway. It was discovered why? Because they cause necrosis of tumor cells. It was cytotoxic for tumor cells. It's associated with radiation-induced complications like septic shock. IL-1 and IL-6 do pretty much the same thing. Induce fever, they have inflammatory responses. And then finally, just to mention, interferon also inhibits cell proliferation. So if one were to look at the cytokines, I need to point out a couple of these that are really important. Please look at this GCSF, CSF, and the lymphocyte-inducible factor. These are restorative of bone marrow function in animals that have been irradiated. And frequently for patients that have received a dose of radiation by accident and accidental exposure, we will give them colony-stimulating factors to stimulate their marrow to divide. While there are some others that are restorative, they are also sensitizers. There are very few that we found that are restorative of intestine. There is one that's been found to be protective in intestines, and people are working with that a little bit, but I would certainly know this GCSF and GM-CSF as being very important proteins. And then IL-1 has protective capabilities and some restorative capabilities. It was explored early on as a potential use in patients that were receiving radiation exposure. The problem is it causes fever and a lot of side effects, and therefore it became problematic. Now, here is the story on the different transcription factors that are activated by radiation. P53, we just mentioned, binds to its response elements. It works in a dose range of around 0.2 to 20 gray. There are about 100 genes or more that are known. It turns on growth, arrest, and apoptosis. NF-kappa B we just mentioned, and I think I said it was 5 gray. It's 0.5 gray to 20 gray that is where it acts, and it works by turning on inflammatory cytokines. AP1 is another transcription factor. It works predominantly at higher doses. It turns on cytokines. AP1 is made up of two different protein subunits. Actually, it's made up of multiple ones, but the two that are important are FOS and Jun that bind together normally as four proteins bound together. There are some other proteins that sometimes are in there, like some of the FRAs and things like that, but FOS and Jun are the most important. EGR is another transcription factor. It binds at very high doses, 4 to 20 gray, and it is found in a variety of different growth factors as well. So if you look at the ones that are involved in cytokine response, really NF-kappa B, AP1, and EGR are all involved there. SP1 is listed here, but SP1 is turned on in so many different systems that it's hard to predict that it's just going to be effective. I want to mention a few things about tumor cure probability. When we think about a tumor of 1 gram, which is maybe we're getting better at detecting them now, but still I would say most that walk through the door are coming in at around 1 gram or bigger. They are made up by definition of 10 to the 9th cells and have gone through 30 doubling times. By the time the tumor reaches 1 kilogram in size, it is probably going to kill the patient because the body can't sustain that much excess mass. And so there's a narrow range from 1 gram to 1 kilogram where we can treat these people. Tumor cure probability is based on this idea that the probability is equal to e to the minus n. It's based on Poisson statistics. I don't have the time to go through that right now, but what kind of want to mention in a context, a tumor control dose of 37 is going to leave about 1 cell per tumor. A TCD90 is going to leave 1 cell per tumor, or 10 to the minus 1 cells per tumor, or 1 cell in 10 patients. A TCD95 would leave 0.05 cells per tumor, or 5 cells in 100 patients, and its TCD99 would leave 1 cell in 100 patients. Generally, in small tumors, there's a good correlation between potential doubling time and volume doubling time. For large tumors, the volume doubling time is really much greater than the potential doubling time. The tumor volume increases about 3 times faster than the diameter of the tumor. And remember that old formula that you learned someplace in high school, that the volume is equal to 4/3 times pi r cubed. The growth fraction for most tumors is 40 to 60%, but that can vary considerably. That's just sort of the average for what we would see clinically. There is a cell loss factor involved here, and it's the balance between the proliferation that's taking place and the cell loss. Sarcomas have a lower cell loss factor than carcinomas, probably because and cell loss factor is the dominant growth rate determining factor in carcinomas. And what we would say is lymphomas have a high rate of apoptosis. Carcinomas have a moderate rate, and sarcomas have a very low rate of apoptosis, and that might be what plays a role here in this difference between carcinomas and sarcomas. Generally, carcinomas are going to arise from that epithelial cell types. They appear to be more radioresponsive because the radiation, the cells that have been killed by the radiation are removed by tumor shrinkage and cell loss. Sarcomas appear to be less radioresponsive because the dead cells just don't disappear so easily. And it should be remembered that tumors with this short potential doubling time may have very rapid repopulation time, and so therefore usually we try to keep time between treatments pretty short. Now, I mentioned a few of these latent periods, but I didn't mention the one for cataracts, so I want to mention that. Right now, we say that the threshold dose for a single exposure is 2 gray. I am not convinced that that number is true. I don't think that good experiments have been done to demonstrate that, but we've changed our dose limit for the population, and so therefore, I think it's something that needs to be thought about. It should also be known that radiation-induced cataracts are different than regular cataracts that appear for other reasons, from aging, say. They progress from the subcapsular posterior region. They're sometimes called PSC, posterior subcapsular cataracts. These other latent periods I've mentioned. There's a lot that I cannot, unfortunately, talk much about chemo because, first of all, there's a wealth of information out there. I will mention that there should be that you should have a big focus on looking at specific inhibitors because I think those have become very important, and drugs that are have multiple different kinds of effects would also be important. Again, I'm not going to spend a lot of time on hyperthermia, but I'll mention a few things. Killing is going to be dependent on exposure. There is the target for hyperthermia. The target for radiation is what? It's DNA. The target for hyperthermia is what? It's protein. Hyperthermia causes protein denaturation. Thermal tolerance is due to the induction of heat shock proteins. It correlates well with heat shock proteins. The transition temperature is around 42.5, so therefore under 42.5 we're going to have thermal tolerance induced in 2 to 3 hours. Above 43 degrees or at 42.5 or higher, we're not going to have as much thermal tolerance developed. It's interesting that hypoxic cells are as responsive to high heat as are oxic cells, and so therefore people thought, whoa, this is going to work great with radiation, and I think we might see it coming back with new modes of being able to deliver heat with nanotechnology and others. Late S is the most sensitive to heat. Heat is more easily carried away from normal tissues than from tumors, so you can get a pretty good focus of heat in the tumors. Sublethal damage repair is inhibited if heat is administered during the interfraction interval. Why? Probably because you're getting rid of any proteins that would be important in the repair, whereas potential lethal damage repair is inhibited only if it's given during the course of radiation. I'm not going to go through all these, but I have some methods of assay for tumor survival that would be important for you to take a look at. I actually have a moment. I have a little bit more on some of these that I'll talk about, but I think this summary is actually useful. Here's a summary that looks at the methods for normal tissue toxicity and measuring them. In particular, I would probably think a little bit about the jejunal crypt cell assay, which is shown here, where we're trying to do in an animal a cell survival curve. And then here are some of the assays that were done for different doses for measuring DNA damage itself. And among the most important to learn here would be a few things. Number one, the difference between alkaline and neutral elution, and any alkaline assay and any neutral assay. Alkaline assays are able to detect single-strand breaks that include, double-strand breaks are actually what? Two single-strand breaks in close proximity, right? So single-strand breaks can be detected by alkaline, that means single and double-stranded. But neutral assays will only pick up double-strand breaks. So this is actually an error on this slide that I wanted to point out. Chromosome aberrations we discussed. We didn't talk about the FISH fluorescence in situ hybridization, but that assay is worth remembering. And then I want to mention the gamma H2AX assay. It does not measure DNA damage. It measures DNA damage in the process of becoming repaired, but because it's so very sensitive, people use it often. That I think that assay is worth thinking about. Here are the 4 R's of radiobiology, and let me now put them in the context. Early reacting tissues, late reacting tissues, and tumor cells all have repair. We wish the tumor cells didn't, but they do, and it occurs in a range of 1 to 4 hours. Redistribution in the cell cycle occurs in early reacting tissues in tumor. It doesn't happen as much in late reacting tissues, mostly because those cells are not dividing so rapidly. The time frame is normally 48 hours. Repopulation is fast in early reacting and tumor. It's slow in late reacting tissues, and it is 2 to 4 weeks for early reacting tissues, 6 weeks for late reacting tissues. Reoxygenation is not really related to normal tissues. It does occur in the tumor, and it takes 1 to 4 days in order to detect it. Now, I put in some stuff on DNA repair here. I don't have that much time to go through it, so I'm going to try to hit the highlights in my last 5 to 10 minutes here. And I'll try to hit the highlights of a few other things too. Of the molecular DNA repair, I would understand base excision repair, nucleotide excision repair, and double-strand break repair as being the most important. Single-strand annealing, which occurs mostly in yeast systems, I don't think I would be as aware of that. It's just important that it exists. When cells are treated with ionizing radiation, they get mostly base damage and double-strand break damage, so we're going to have BER and double-strand break repair as being important. When cells are exposed to UV damage, NER occurs, and there is some base excision repair that occurs for UV damage as well. I would remember those distinctions. Here are some of the diseases that have been identified, and they are pretty specific. Xeroderma pigmentosum, Cockayne syndrome, trichothiodystrophy are all UV sensitivity. SCID and ataxia-telangiectasia and Niemann breakage syndrome are all for ionizing radiation. Fanconi's anemia is mostly for mitomycin C and cross-linking agents. And then we have these Werner's and Bloom syndrome, which are very unusual inherited disorder, both of the RECQ helicases. ATM is the master switch protein. It by itself is not a DNA repair protein, but it phosphorylates just about everything in all phases of the cell cycle, except, as I mentioned before, ATR, which is phosphorylating here in late G2 phase of the cell cycle. This phosphorylates P53. It phosphorylates the check proteins, which regulate the G2 phase of the cell cycle. It phosphorylates BRCA, which is going to have an important role in double-strand break repair, and Niemann breakage syndrome 1 protein, which is also important in DNA repair. Here is the BER pathway, and I actually really like this diagram of the BER pathway because it points out that single-strand break repair is a portion of the base excision repair pathway. They actually don't have that much in common, except they have a common intermediate. So let's go through these. Base excision repair, the first step involves a glycosylase. What does the glycosylase do? The glycosylase removes the sugar residue and from the base, kicks the damaged base out. The apeirotic endonuclease comes in, makes a nick in the DNA to make it be single-stranded, and here we have this nice even break that's an intermediate. Polymerase beta, DNA polymerase beta, fixes the damage from base excision repair, binds to a protein called XRCC1, X-ray cross-complementing protein 1. inserts in the correct base, ligase 3 seals the deal, and we are left with a corrected sequence from a base excision repair. There is no separation of damage, recognition, and repair processes in base excision repair. There will be in NER and double-strand break repair. Okay, single-strand break repair doesn't look that much alike. Single-strand break repair, please remember, uses the PARP protein. We just said before that PARP was involved in DNA repair, and it gets inhibited when the cell's undergoing apoptosis. Here we have PARP binds to XRCC1, so this is common between these two different pathways. It now takes the X-ray-induced sort of dirty break because X-rays don't cause clean ends, and polynucleotide kinase cleans up the ends to make sure that we have a phosphate at one end and a hydroxyl at the other. This is the common intermediate between these. Now, a different set of polymerases fixes the single-strand break. DNA polymerase delta or epsilon, one of the two of them, binds to PCNA. PCNA was that protein induced by P53. It synthesizes in, takes off this little flap of about anywhere from 2 to 10 bases, cuts it with flap endonuclease. Ligase 1 comes in and seals it, and we've corrected it. So different proteins in most cases, with the exception of XRCC1, which is involved in both, but because of this common intermediate, they're considered to be on the same pathway. Now, nucleotide excision repair has a recognition and a repair component that are separated. This is going to be mostly for big, bulky adducts that one finds in the DNA from UV damage. Here, there's a cross-link that exists here. We have the proteins that are binding this and recognizing the damage. The XP proteins, XPEs, and the Cs, that got their names from xeroderma pigmentosum. They bind, they then mark off this lesion, and I want you to notice that what's going to get cut here is a larger sequence. It's going to be 5 bases on one end and approximately 30 bases on the other end, or maybe 25, and we're going to get this cutting off of this very big sequence. Polymerase is going to bind to it, go through with PCNA, fill in the gap, and this is going to be polymerase delta and epsilon, by the way, and ligate it together. So actually, there's some reminiscent sequences between this NER and the single-strand break repair that we just talked about. Now, the double-strand break repair, a very important thing to understand is that there are two types, homologous recombination repair and non-homologous end joining, but here's the story that's important. Non-homologous end joining happens throughout the entire cell cycle, G0, G1. What are most cells in the body? I said this already, G0, G1 phase, so therefore non-homologous end joining is going to be the most common form of repair. Homologous recombination repair only occurs in late S, G2, and early M phase of the cell cycle. It is an error-free repair mechanism because it uses the duplicate chromosome in order to carry out its repair. Non-homologous end joining is error-prone because it doesn't use anything as its template. So here we've got the story. This is the non-homologous end joining repair, NHEJ, so-called. ATM becomes activated. ATM, very important complex here, MRE11, RAD50, MBS1. Memorize this complex. ATM phosphorylates this, also phosphorylates gamma H2AX. These move to the site where there is the damage, recruits Q70, Q80, and DNA PKCS. That becomes phosphorylated also by ATM or by itself. It does autophosphorylation. Artemis is recruited, polymerase beta comes in and fixes this, and it becomes sealed with the ligase. What's the problem here? There's a breakup here. They just get sealed together. If there is a clipping away of some of the DNA sequence, it will be lost and be stuck here with us. Here is the homologous recombination repair. Again, ATM is important. Again, MRE11, RAD50, MBS1. Please remember that MRE11, RAD50, MBS1, sometimes called the MRN complex, that complex is used in both forms of double-strand break repair, non-homologous end joining and homologous recombination repair. But here's the thing that's cool about this technique. When the cell uses this, it's got a duplicate chromosome, so it uses these replication protein A to make the DNA stay single-stranded. It does a strand invasion. The so-called holiday junction occurs. The holiday junction occurs only in homologous recombination. It has a special way in which that is resolved, and we get ligation that takes place. This is an error-prone process because it's copying from another chromosome. Finally, I want to mention this. This is not important from a radiation perspective. This is mismatch repair. Mismatch repair is mostly for bases that are mismatched, involves MSH2, MSH6 proteins, multiple different pathways associated with it. Probably one of the most important things to remember is it's associated with hereditary non-polypoid colon carcinoma for mutations of these. Now, I do want to mention a couple of things that I only have 3 minutes left. I have to go to another building. I want to mention a couple of things that are important that are methods associated. I would probably learn something about the caspase, the CRISPR-Cas9 method, which has become important recently for being able to cut out and put in very specific DNA sequences. This has revolutionized what we do in the laboratory. This is a diagram of how this works, where you've got a large target 20 base pair sequence that can be guided by a guiding RNA, allow for the cutting out of a sequence and the insertion of a new sequence. It does use NHEJ. And then I have some other information on animal models with the different types of syngeneic mouse-to-mouse systems that can be used. The xenograft, which is human-to-mouse, the transgenic mouse, and the PDX mouse, which is a form of a xenograft mouse, which is being used a lot in labs. Promoter assays are mentioned here, reporter gene assays, a promoter bashing experiment. I'm sorry I can't get through all these, but the information's there. This will all be up for you. One last point to bring up is the Western blot involves proteins and antibodies. The Northern blot involves RNA and DNA hybridizing, and the Southern blot involves DNA to DNA hybrids. And I'm sorry, but I have to go. So, Jelaine, I'm turning it back to you.